It's I commented earlier in that it's just ironic that we are talking about going through the psychology course, especially in the midst of everything that's going on in the world and in the news. And it just kind of highlights some of the features. Every one of us are experiencing some kind of feature of either depression or maybe anxiety. Maybe we felt like we lost a little bit of our normalcy. And this really illustrates my point when I was talking about the 3Ds, right? The 3Ds for diagnosis is what? Does anybody remember? Let me help you out.
Dysfunction.
Dysfunction, deviant thoughts, behaviors and actions or feelings, and distress. Okay, so the 3Ds. Undoubtedly, we are all experiencing those things. However, when we look at deviancy, we look at given the situation, is everybody else acting the same way? Do we all experience some kind of loss? Now, prior to the events over the past couple months, if somebody was isolated, working from their home, not going out and doing anything, expressing a loss of interest, all those feeling blue, having lack of energy, right? All those might be indicators to something a little bit more sinister, right? And we have to really look at that. And I'm not downplaying that some people out there might genuinely have some deep-seated some depression and sadness going on there that might be more severe in intensity and frequency. Nonetheless, we are all feeling that, right? Given the situation. So that kind of normalizes it a little bit. Doesn't make it better. It just makes it normal. So that's kind of what we look at. Like I said, outside of the confines of what we're going through right now, if somebody came into my office and sat down and told me these features that they're expressing, I would probably be more likely to diagnose with some kind of depression or anxiety or something. But and that, that's not taking away that we don't deal with those labels currently, but it certainly guides us as to what's normal and what's abnormal. And that was my whole point for this whole thing. All right. So I left off with anxiety disorders. Okay. So I walked you through last time how to go through the formal diagnosis, look at those criteria, and then see how many of those that we meet to guide us towards a diagnosis. Now, that's not to say we are going to officially diagnose somebody with a disorder. Of course, it gives us a direction as to what to look at, other features, and figure out ways that we can probably further test, maybe use some kind of psychometric test to make a determination as to what that does. And a diagnosis, all that really gives us is a label. It gives us a direction. Once we have that label, we can start establishing maybe psychopharmacological treatments like medication. We can maybe prescribe some kind of some other kind of treatment like cognitive behavioral treatment or dialectical behavioral treatment, which we'll talk about a little bit next week. We don't have a lot of time next week, but it's certainly in your book. I'll cover some of the important stuff. Maybe group therapy, maybe some kind of drug intervention. So based on whatever assessment we have and the criteria that they're meeting within that DSM-5, we can guide them towards better treatment. And that's all that really does. So moving on, we talked about anxiety disorder. We had mentioned about obsessive, some of the other anxiety disorders that make an appearance. And one of those, probably one of the most popular talked about ones is OCD, right? We see it a lot. We see it a lot in our media. We have it in our language. Like I hear somebody might put forks in a certain way in a drawer and they say, oh my gosh, it's my OCD, which is, kind of funny. We kind of make light of that sometimes, but is it OCD? Can we diagnose it with OCD? I would say 99.9% of the times that people say it's my OCD, probably not. People with OCD, it's a serious affliction. I think I have some videos on D2L that kind of that demonstrate how severe it gets. It's a debilitating disorder. And people that have that, usually, again, highly distressed, not only for themselves, but for those around them, very deviant behavior, and very dysfunctional. right? They spend so much time worrying about it that they can't do anything else. They can't care for themselves. They can't care for their kids. They can't get to work on time, right? So all things, bad things happen with a formal diagnosis of OCD. So I'm going to share my screen with you because I kind of want to go through. I listed out some of these criteria, and I think it's important for you to see those as we go through them, just to kind of give you an idea of what we look at for making these diagnoses. Okay. All right. So hopefully you can see my screen here. So OCD, I don't exactly have, oops, I don't have a slide for this one. Obsessive compulsive disorder. Okay, so there are two key words here, okay, that have to be present in order for us to really diagnose or look at seriously if somebody is afflicted with this. The first one is obsession. The obsession part of this is a reoccurrent or persistent, intrusive, unwanted thought or behavior. Thought that's causing anxiety or distress. Okay, so it's recurrent. And intrusive. That's the key to this. Intrusive. Can't get rid of it. No matter what you're doing and what you're thinking about, it's there. It's occupying your mind. So that would be an obsession. So for example, how many of you heard a song or maybe thought of a song and it stayed within your mind for hours or days? You couldn't get rid of it, right? Mine is Yellow Submarine by the Beatles. Every time I hear Yellow Submarine, it's stuck in my brain for days. And I'm sorry if that sticks with you now, but for some reason, once I start hearing it and singing it, it just sticks in there. That would be an example of recurrent. Now, is it necessarily intrusive? Now, if I'm trying to think of something else, like I'm trying to think of where I put my car keys, or I'm trying to put my lesson together for the class, and all of a sudden all I'm thinking about is Yellow Submarine in my head, that might be a problem. That would be considered intrusive, okay? So the second part to obsession is any attempts to ignore or suppress such thoughts, or to even neutralize them with some other thought or action are very difficult, right? So that's the other part of intrusive. Can't ignore. So how does this different? How does this differ? How does this differ from, say, you're looking at your utensil drawer and you see a fork in the spoon slot? How is that different? What would an obsession look like in that example?
The person would have to like immediately probably rearrange everything.
Okay, maybe, and we'll get to the compulsion first in just a minute. So not necessarily rearranging anything. Remember, obsession is thought, just thought.
So would
No
they
action.
think about it?
They would think about it constantly. They wouldn't be able to move on. They may go outside their house. They may go out for dinner, and the only thing in their mind is that darn fork in that spoon slot. Okay, that's an obsession. So the other part of OCD,
yeah, I can relate to that, because every time, like when I go out for dinner, especially if I'm going out for wings, like, and I'll be honest, wings are a weakness of mine. Like that's like my all-time favorite. So like every time I'm going out for wings, like usually throughout the day, that's pretty much all I can think about.
Okay. So intrusive thoughts. Now, what would happen if, say, for example, you have those thoughts of wings and you can't eat anything else? You can't do anything else until you get those wings, right?
Done that. I actually have done that before. But I'm trying not to, because like I don't want, because like this, not eating like the whole day, like that's not healthy. So
Right. And we would have to look at that from a dysfunctional standpoint to see, is there dysfunction? Maybe I'm hearing a little bit of distress, definitely some deviant thoughts and feelings about it, but is it dysfunctional? And that's what we've been talking about, covering those 3 Ds to see if we're going to consider a diagnosis of some sort. So the obsession is the thought part of it, right? And I want to keep in mind as I'm going through all this, be cautious. Don't self-diagnose yourself, okay? Because a lot of us have these features. I have mine, okay? I have things that I do throughout. For example, before I go to bed, I ensure that all the doors are locked, even though my wife and my son say that, yeah, I lock the doors. For me, it's more peace of mind for me to go through. Is that trust issues? Maybe, but for the most part, it's something that eases my anxiety, which is really kind of a compulsion. Okay. Now, again, is it unhealthy? Probably not. Now, if I get up every hour throughout the night and I'm checking those doors, that might be a problem, because why? I'm losing sleep. I'm not going to be able to function. I'm going to be cranky the next day. So now we're crossing into the realm of dysfunction. Okay. So you kind of see where I'm getting with this. So compulsion is repetitive behaviors. And I call these ritualistic. Ritualistic behaviors, okay? Because they form, they serve a purpose, and they happen almost automatically within the person, just to relieve that these behaviors are aimed at preventing anxiety, preventing or reducing anxiety. Okay, so that's the function. That's the idea behind compulsions, and they go hand in hand. So we have the obsessive thought, which is causing the anxiety, and then we have the compulsion that helps to prevent or even reduce anxiety. All right, let me give you an example. Washing hands. Some people, we might say, are quote unquote OCD about washing their hands. Some of us probably more than a couple months ago. Many of us can probably relate to this. We're washing our hands and sanitizing our hands a lot more than what we used to. Is that OCD? Probably not, okay, because it does serve a function. We are reducing anxiety, but it is not necessarily, it's an actual fear. It's not irrational in any way. So, but for somebody that goes above and beyond and washes their hands for 30 minutes at a time, 5-6 times a day, to the point, with scalding hot water where they're sustaining boils on their hand, that might be a bit much, right? And that might be something that we would look at for the diagnosis. Okay. So the other part, so after we can define these two, obsessive and compulsive, we're gonna go back and we're gonna say, are these obsessions or compulsions time consuming? Okay. So for example, what I just said, like 5 to 6 times a day for 30 minutes. That might be excessive. That's taken away from the person's functionality. You think they're going to be able to hold down a job if they're breaking away every 2 minutes to wash their hands for 30 minutes? Probably not. That's going to cause dysfunction. Are they going to be able to look after their children with that, right? So one thing to note with OCD was really looked at on the anxiety scale with DSM-4. DSM-5, they kind of moved it. They moved it from classifying it as an anxiety disorder and put it into an obsessive compulsive related disorders, and kind of mixed in a personality disorder with that, which I'll talk about here shortly. Okay. So any questions on OCD? Or any comments? And like I said, many of us have similar features of this. And as we talk about all these, you're going to identify some, like narcissistic personality. Some of us have inflated egos on certain issues. Does that make us narcissists? No. Do we have the features? Yes. But that doesn't make it that any of us are narcissistic. Many of us might like thrill seeking, like skydiving or something. Thrill seeking is a feature within antisocial personality disorder. But does that make us antisocial personality? No, not at all. It just means that we have a component or a feature of that. Okay. All right. So let's talk about, I kind of briefly touched upon anxiety in terms of PTSD. Okay, so PTSD, which stands for post-traumatic stress disorder, is a condition. It's a condition that persists long after somebody experiences a traumatic event. Okay, so we have a couple components here. Person has to first experience trauma. Okay, so trauma happens. Person reacts to trauma. Could be a while after, right? So they may have a couple days that that's all that's on their mind. They can't get over that. And then we have long-term symptoms. Now, within this spectrum, we also have acute stress disorder, okay? Acute stress disorder are symptoms that occur immediately after a traumatic event. Somebody might be in shock, for example. They might be stunned. They're in disbelief. They're despondent, right? They may be shaking, okay? These are normal reactions to something that's traumatic. They may have nightmares shortly after that traumatic event. Okay, so that is a pretty normal reaction, okay? And we call that, again, ASD, acute stress disorder. Oops, I think it's one too many C's, acute. Now, where this morphs or manifests into something a little bit more serious is when this prolongs over a long period of time, or it gets worse. It could happen, okay? Let's say that the nightmares get more intense. It gets to the point where the person's afraid to sleep anymore. Maybe they're having an alarm reaction into the middle of the night, right? And we see this a lot. I'm going to use, because this is a subject that's very near and dear to me, are combat veterans, okay? Combat veterans that experience near-death experiences, either of their own life or their buddy's life, their battle buddy, might see some horrific things and they react to it, right? We see that. They experience a trauma, they react to it, and they have long-term symptoms. So they're going to have nightmares, they're going to come home and they're going to be on edge. They're probably not sleeping well. We usually see a high rate of substance use and substance abuse in these individuals because they're trying to numb those feelings or dissociate because that's their goal, right? Now, for post-traumatic PTSD to really be classified, we have to see these ASD, and we have to see the reaction and the long-term symptoms much more like 6 months past the trauma. If it goes 6 months past the trauma, or their levels of alarm, like their body endures alarm features, then we can start looking at PTSD. And again, this would be something that would benefit both the clinician and the patient or the client to go seek a specialist and maybe get a formal assessment done. Okay, so what I did to, and again, these are both classified as anxiety disorder. So what I did here is I kind of captured what we look at with PTSD according to the DSM-5, okay? And as you can see here, I wasn't lying to you. We have exposure to a traumatic event, okay? So if you look on this column here, symptoms required. So if you remember back when we were looking at anxiety disorders, has to meet one of the following criteria, or has to meet 3 of the following criteria for us to endorse these criteria on the left-hand side. Okay, so for A, exposure to traumatic events, let's come up with a hypothetical situation. We'll say Private Maria Smith comes back from Afghanistan. Her entire platoon just got shelled. Okay. So she's having nightmares. This was about a year ago. She's having nightmares. She can't attend any kind of events that include firecrackers or fireworks or anything. She tends to isolate herself. She might be engaging in severe drinking of alcohol or something like that, right, to numb her feelings. So we can say that she directly experienced an event or witnessed an event, right? Any of these really. Experienced repeated or extreme exposure to aversive details of an event. So for example, children that endure either sexual or physical trauma through their entire childhood, that would be considered, that would be really, that we would consider that to be, sorry, I just lost my screen here. That would be considered exposure to a traumatic event or a long one, okay? So we would endorse A because Private Smith was exposed to death. Intrusion systems. So we need to meet one of these off to the right here. So intrusive distressing memory. Of course, we can say that. Recurring distressing trauma. Intense psychological distress, right? She doesn't go to anything that, so we can really endorse several of these based on what you know about Private Maria Smith, right? Avoidance system. I said she stays home, right? Avoidance of thoughts and memories, probably through the use of alcohol, right? And stays away from places that have fireworks. So all we need to do is meet one of these, but we met both. Negative alterations in cognitions and mood. Dissociation of amnesia, don't have enough information about. Persistent distort blame of self. Maybe if we talk to her, we would find that out. She has some kind of self-blame for it. But anyway, you kind of get the idea here. We just go through each one of these, and based on how many of these we need to endorse, we can say we can diagnose her with PTSD and get the help that she needs, and maybe some further testing to see like what areas she can do, she can most be beneficial in. All right. Any questions or any comments on PTSD? All right. Now we have, I do want to make one note here that we do really consider PTSD outside the realm. Again, I talked about wartime situations. We can look at PTSD through child abuse, which is a very real thing. We can look at PTSD as some kind of sexual trauma, right? And even being robbed at gunpoint, some kind of violence against another person that makes the person feel threatened to their lives. We can really see PTSD in those areas. We can see PTSD in bullying, okay, as a result of bullying. Now, again, we have to meet each one of these criteria, and it's not easy. We may have some lingering self-defense mechanisms that have sprung up because of that. That doesn't necessarily mean it's PTSD, if you know what I mean, okay? So we have to really look at this critically before we move forward with these diagnoses. And again, the problem with labels, like for example, if anybody wants to get into law enforcement and they have a diagnosis of PTSD, or they have a diagnosis of addiction disorder or something like that, that could be a big problem for getting people jobs that they want. So, you know, we use it sparingly, we use it in a way that's going to be beneficial, and we weigh the risks to whether or not they're going to improve the quality of their life. Okay. All right. So the other, I'm going to kind of move into dissociative disorders. Now, I'm not going to spend a lot of time with dissociative disorders. Okay. And the reason being is it's kind of a rabbit hole, if you will, okay? Figuratively, of course. Dissociative disorders there are several types that we can look at, but dissociate means that we step away. Our psyche steps away from reality. Okay, it steps away from something that might cause a lot of trouble and stress for us. Okay, so what we look at with dissociative disorders is like memory loss. People, you hear about it all the time. People endure a stressful situation and they block it from their memory. And according to Sigmund Freud, we call these suppressed memories. Now, I will say there's a lot of evidence that supports that we don't necessarily lose memories from traumatic events. In fact, it's quite the opposite. We have heightened memories from traumatic events. A lot of evidence points that direction. We once thought that dissociative amnesia was a very popular thing with trauma, to the point where we were putting people under hypnosis to try and drag out information from them. The problem with that is hypnosis is what? It's putting somebody in an altered state and providing them suggestible ways to imagine the world around them, which could be, if not done skillfully and not done carefully, could implant a memory in somebody that didn't previously exist, right? Especially when they're claiming it was too painful for them to remember. So we're looking at dissociative amnesia more as a choice, like the mind's choice not to look at those things because it brings up too much memory and the person says, I'm not going to think about it. All right. So we're kind of associating it more along those lines. You know, again, it does exist in the DSM, but it's not nearly as prevalent as we once thought it was. So dissociative amnesia is one of the things that we consider, and that's just memory loss for personal information, either partial or complete, usually with some kind of trauma. Dissociative fugue. Dissociative fugue is doing something like maybe getting in a car and driving halfway across the country and then realizing that you have no clue how you got there. Okay. Now, many of us probably have very small snippets of that, like, right? Maybe you got in a car and you were driving somewhere and you forgot why you were going there or something like that. You know, that's not quite it. Dissociative fugue is actually a big action. And we usually see that in criminal defenses, mostly where they say they blacked out. And when they woke up, somebody was pummeled to death on the floor beside them. That's more dissociative fugue. Okay. And of course, the grandma, the big kahuna is DID, otherwise known as multiple personality disorder, right? How many of you have heard of that? Multiple personality. Okay. In reality, a while back, like DSM-3, multiple personality was a term. We now call this dissociative.
Does anybody seen the movie Split?
Yeah.
I was just going to say that. Yep. Dissociative identity disorder. Yeah. So DID is what it's now called. So with DID, it's very contentious. It's something I can say that I have had probably around 3 dozen clients that had claimed that they had DID. And it's one of those weird things that it's much more rare than people really claim it to be. Okay. Because it's kind of illustrious. It's kind of one of those cool psychological disorders that people just want to pretend like they have multiple personalities within them, and each of us do, right? Each of us have different faces that we present to different people, and that's not what we're talking about. We're talking about, when we're considering dissociation, is we're talking about we have one personality, and then all of a sudden, like a switch, that part of our mind, that part of our brain turns off, and then another identity becomes available. And both identities, according to DID in DSM-5, the DID criteria is they don't have knowledge of each other, or they don't interact with each other. They don't control each other. It's like literally 2 people in a body that don't have any interaction with each other or control. Okay, so that's what DID is. And again, I've had several clients. I've had many clients that claim that they had DID or multiple personality. And then my job is to kind of work through, well, why do you think you have that? And then they tell me, and then I work through their stories. And most of the time I find, in fact, all the times I have found significant holes in their theory, holes in their inconsistencies, if you will. Okay, maybe they forgot which identity they were or what the name was, and upon challenging them and saying, "Oh, I thought you said so and so did that," and then they double back, and now I can kind of see that this has been an acting thing. I'm not saying in any way that this doesn't exist. I'm just saying that the evidence does not support that the number of people that come forward with DID is necessarily as large as the actual diagnosis out there. It's a very, very rare thing. I've never personally encountered it. I don't know anybody that has encountered it, but there are certainly some cases out there that that do show that. Okay. All right. So those are just some. So one of the things that we look at with dissociation is we look at the psychodynamic. Now, if you remember reading back about a couple chapters ago in regards with personality and Freud, right? One of Freud's personality theories suggested that we develop mechanisms based on our life's experience, mostly from trauma, right? And that can be projection, that could be displacement. But one of them he thought was repression. He thought that we repress memories, and within that repression, we can repress those stressful events so hard that another personality comes out to kind of be the savior, right? It's kind of like an archetype of some sort, according to Jung, Carl Jung. So that's really the psychodynamic, is that something happened so significant in our past that we had to develop an entire personality and dissociate from that personality that endured that event. Okay, so that's the psychodynamic approach. The cognitive behavioral approach looks at more avoidance. We look at it at avoiding stressful things. Like, for example, how many of you have touched a hot stove before? What do we do when we touch something that is uncomfortable? We avoid it. We don't get near it, right? For me, it's bees. I've been stung multiple times by bees. So anytime there's a bee in the room, I'm not there, right? That's the cognitive behavioral explanation, is that if something is too stressful for us to deal with, we avoid. We don't want to think about it. We try and stay away from it. We don't want to talk about it. Okay. And then, of course, they have the biological approach to dissociative, which could be some kind of depersonalization due to activities in the brain, for example. Okay. So trying to think of an example of what that would be. So if for example, let's say sexual trauma, if somebody has been sexually traumatized, they may, again, avoid certain areas of their body because that part causes them pain, or at one point caused them pain and is no longer comfortable for them. Okay, so those are just some explanations, popular explanations of dissociative disorder. Okay. All right, moving on. Any questions on dissociative disorders? I know I'm kind of flying through these at breakneck speed, but I certainly want to try and get to all of these before we depart today. All right, so the next part we're going to talk about are mood disorders, okay? First one is major depressive disorder, MDD. You might hear depression or major depression, or the correct term is MDD, major depressive mood disorder. Okay, is what we call this. Now, moods, we talked about moods a couple chapters ago. Moods are how we present what's on the inside to the outside. That's our broadcasting, right? And we do that through gestures. We do that through language. We can sense somebody is in a bad mood just by how they talk or how they respond. That's different from what they normally do, if they deviate in any kind of way. So moods are, they're different than feelings, okay? Feelings are internal, And we can't really tell how somebody feels until they communicate that. And they usually do that through some kind of expression of emotion or mood. All right. So when we look at mood, we're looking at the external factors. So a mood can be, what are some moods that we can detect? We can see sad, right? We can see happy or elated, right? We can see, trying to think of what, surprised, right? Maybe that's an emotion. Okay, so these are expressed through something we call affect. An affect is an emotional reaction. So for example, our best cat, Fluffy, I know this is going to be really, hopefully this is going to be traumatizing, but we see Fluffy pass away. Okay. And that makes us sad. Our affect is going to be crying, right? We're not going to be happy about it. We're going to be sad because Fluffy is now no longer with us. So how we express that is through our emotional reaction called affect. So disorders of mood look like they're disturbances. Now, what do I mean by disturbance? So maybe they're not showing the correct mood. Maybe Fluffy passing away, we start laughing about that, right? That's a disturbance of mood. Or maybe Fluffy had passed and we can't not be sad for 6 months or a year after that has happened. That is a disturbance, right? And that can range, any disturbance can range anywhere from mild to moderate to severe or extreme. So somebody, for example, we're talking about MDD, major depressive disorder. Somebody with major depression might have mild symptoms. They might be a little blue. They might have a hard time getting up in the morning. Or that might be a little bit more moderate, right? Now they're constantly thinking about their job that they could be losing, or a family member that they lost a while ago, 6, 7, 8 years ago, right? That would be more on the moderate side. And then of course we have severe, which we would look at somebody that is contemplating ending their life. We call that suicidal ideation. And it is probably the worst outcome that we can ever experience in the mental health field, okay? So suicidal ideation isn't necessarily a bad thing. It's a very normal idea that people have when they get into moderate disturbance of their mood, okay? We call that learned helplessness. After a while, they just don't have any answers. And we, as humans, we need to have answers. We need to figure out our own problems. And when we can't do that for some reason, we go to, well, then what's the point? If I can't solve the problems of the world, then maybe the problem is me, right? And that's a very dangerous spot, okay? So within suicidal ideation, we look at 3 things. We look at thought, okay? We look at plans, and we look at intent. It's very, very, very common. I would say at least most of my clients that are battling depression sometimes go to thoughts. Thoughts can be vague. What's the point of life? Why am I here? Why am I a burden to my family? Not really crossed into plans yet, and definitely not intent, but they're thinking along those lines. And that's something that we can work with on an outpatient basis. So normally, and I'm kind of getting ahead of myself, but when we're dealing with suicidal ideation, we look at how can we keep you safe? What are some things we can put into place so that if plans and intent start showing up, we can get you the help that you need, okay? Now, suicidal ideation, this is a very, very tough thing to really wrap our minds around, because number one, with the myth and stigma surrounded with mental health, people that are experiencing these thoughts, do you think that they're likely to go and seek help? Probably not. Probably not. And the reason being is because they associate suicidal ideation with getting locked up, getting hospitalized, put in a padded room, and being looked at by doctors all day. And that's not the case, okay? People with suicidal ideation, if they're evaluated as mild or even moderate, can be easily handled on an outpatient basis. Now, when we start looking at somebody that has plans, and we'll ask them about those plans. What are your plans? Do you plan on doing this? Do you have an idea like when this is going to happen? Okay. So for example, let's say Maria, Private Maria Smith, she's been battling this trauma for her entire life, and she blames herself in so many ways, and she just thinks that life isn't worth living. So I, as her therapist, I talk to her and I say, how severe is this? How important is it for you? What are your safeties? Why are you existing here today? Well, I have my kids, I have my parents, and I love them very much. My faith won't, it would be terrible if, those are safety things. And I can look at those and say, all right, so we have safety things in place. Let's come up with a safety plan to figure out a way to keep you safe in case this crosses into plans and intent. But as long as those plans and intent aren't there, we're good. Now, if she says, I've oftentimes thought about just kind of putting my service pistol to my head and taking my own life. Okay. Do you have access to that service pistol? Well, yes. If you had those thoughts and you thought you were going to do it, could you give that service pistol to somebody else and coming up with a contract with them? Okay. Very important to do that. But of course, and this has happened, I probably a couple more times than I want it to. But sometimes you just get that patient or that client that comes in and says, I've thought about it for a long time. This is how I'm going to do it. And as soon as I walk out that door, that's going to happen. And in those cases, we have what's called, we have a duty to protect. And unfortunately, we try and work with them to get them to go voluntarily to the hospital. But in that case, voluntary hospitalization is absolutely imperative. They can't leave that building without being escorted or followed or transported or something, either by their own will or against their will. Hopefully by their will. That's always the best option. But if it's against their will, usually that means that they're now we're looking at like giving up certain rights. Not necessarily under arrest, but they're certainly going to be not going voluntarily. But so anyway, for any of you that are going into the field and dealing with suicide, that's some of the things that you're just going to think that you're going to encounter. And I remember the first time that I encountered, I spoke with a client. There were two things that really freaked me out is cutters. Okay. Somebody that cuts themselves, they make incisions either in their arms or their legs or their bellies or something, right. Or the wrists. That freaked me out the first time that I encountered that. I thought, oh my gosh, I got to get them to the hospital. It's a very normal thing. Their intent usually isn't suicide. It's to externalize their pain. The other one was somebody said that I've thought about suicide. I can't, and that freaked me out. And I'm thinking, oh my gosh, I got to get them to the hospital, to find out that this has been going on for some time. They've never tried it. They've never came up with a plan. It's just a constant feeling of not wanting to exist anymore. So anyway, I know I kind of droned on about that, and I apologize, but I think it's very important to understand where major depressive disorder and some other disorders that we talk about happen. And the next one, as a matter of fact, so I'm going to kind of just any thoughts? I do want to check in with you. I know this is a very heavy topic, but does anybody care to share any thoughts or comments on suicide or major depression? Okay. All right. So again, as promised, here's the diagnostic criteria for major depressive disorder. Now, I will say it has to occur over a long period of time. Usually about 2-week period is what we look at before we start considering major depressive disorder. Okay. And it has to meet 5 or more of these following symptoms, which some of the things we talked about: depressed mood most of the day, markedly diminished interest and pleasure in all or most of the things, significant weight loss, or does it say gain in here? Yeah, gain as well, because it could go either way with that. Some people like to eat when they become sad, and that could lead to increased weight. Or some people may lose their appetite, especially if it's anxiety driven. Insomnia or hypersomnia. Hypersomnia is sleeping too much. Insomnia is not sleeping or sleeping very little, undersleep. Psychomotor agitation or retardation nearly every day. Okay, observable in others. So maybe they're moving their feet a lot, or maybe they just look like they're fatigued or fatigue, right? Feelings of worthlessness, diminished ability to think or concentrate, and recurrent thought of death. Okay, so 5 or more of these, if they meet these criteria, all within a 2-week period, we can say that we're likely looking at major depressive disorder. And again, we'll talk more about treatment next week for such things. Okay, any questions before we move on to our next topic, which is bipolar mood disorder? Okay, bipolar. This is another popular one that you probably have heard of. Okay, so we have 2 types of bipolar: bipolar 1 and bipolar 2. Both are marked with fluctuation of moods. Okay, but what we see with, I'm going to kind of just do a graph here. So 1 is we see, we'll call this normal functioning. So I'm going to give you 3 colors here. So the normal day-to-day, everybody that, for the most part, everybody that exists in the world kind of has, we all have these little ups and downs, right? Sometimes up, sometimes down. They're usually dependent on the situation or who we interact or whatever. That's a normal situation to occur. What we have with bipolar 1 is what we call the episodes of extreme lows and extreme highs. Okay, so we may see somebody that starts off right about where we are here, and this is bipolar 1. Okay, and they kind of shoot up into what we call mania. This is a manic episode. So mania can be described as like this burst of energy, this explosion of thoughts and ideas and even actions sometimes, right? Maybe they're starting to act a little bit more self-destructive. They're running up their credit cards to make them feel good, right? They just try and they have this void. They just try and fill this void with all sorts of things. We might see increased drug or alcohol use during this period of mania to kind of numb whatever it is, again, to fill that void. What happens at once they get to this upper peak here is they start realizing the reality of things. Okay, so this is kind of a break of reality. Where they have ideas that they're rich, or this is just like a superficial feeling of filling that void. So at some point they get reality up here and realize that, oh my gosh, I ran up my credit card. My spouse or significant other has left me. I've alienated my entire family. I don't have any money to pay my rent. And we experience a crash into depression. Okay, so this crash, and this is kind of where bipolar 1 gets really dangerous, because remember what we talked about before with major depressive disorder. This would be probably on the moderate to severe side, where they start questioning their behaviors and things become so intense and so negative that it's hard for them to really justify living anymore. And bipolar 1 is by far probably the highest rate of suicide that we see because of this reason. Okay, they have this extreme high and they plummet to this extreme low. before some kind of intervention has to happen, usually either hospitalization or medication or something to kind of just bring them back up to normal. Okay. And it's sometimes a slow process. They've got to recover their debts. They got to find a new place to live. They've probably destroyed a relationship in somehow or in some way, but it's going to take an intervention on somebody's part to help them get back up to normal. Okay. And then with medication, they tend to follow the same trajectory that we've seen before. Okay. Pretty normal, right? Now, the problem with bipolar is this reality check here. This break from reality tends to be a problem because usually this needs to be done with specialized training. And I'll talk about this next week, called dialectical behavioral training. And it's very important for them to have maintain their medication regimen. Okay. If that doesn't happen, they can start spinning off into this alternate reality, the skewed reality, and then plummet once again. Okay. So they decimate their lives, and then they come down here, and then reality hits, and they've hit rock bottom. So the problem with medication management, it sounds easy, just take your medications, right? It's not, because they get that feeling that what we call delusions. It's almost delusions of grandeur, is I don't need these medications anymore. I'm fine without medications. And then we see everything's good for a while. They stop medications here. And then we see that lifting, that lofting back up into delusion, into mania again. Okay. Which we all know what follows is that plummet. Okay. So very dangerous sequence of events. It is very manageable. It just has to, it requires that individual and a good support system around them to help them maintain this nice, even wave. Okay. So experiencing the ups and downs as normal. Now, with bipolar 2, a little bit different. Okay. We may have periods of mania. Okay. We may have explosions of interest. We may have ideas and feelings that are just good, maybe a little bit of delusions of grandeur, but it doesn't get to the point where they're necessarily spending the entire family fortune. Okay. They're not racking up their credit cards to the point where they're not going to be able to afford rent the next week, but it is an increase, what we call hypomania. Oops, why is this not working? Hypomania. So not mania, not nearly as bad as mania, but it is a lift. And then, of course, they may plummet down here. So it's kind of an exaggerated sine wave here. So we have our ups, but it's not to the point that are dangerous, and we have our lows. Sometimes these lows get to down here, but usually not nearly as bad because they're not recovering from some kind of major life self-destruction period. Okay. Hopefully that makes sense. So any questions? Do we understand bipolar 1 and bipolar 2? Usually there are a couple ways that we look at bipolar. And some of them are behavioral, right? It could be something that they experienced with mom or dad, maybe within their house. They were able to, somebody modeled to them that, yeah, we can, if we want something, we can go out and just spend and spend and spend. And if they don't have that mental acuity to kind of pull themselves back and make good decisions, that could lead them into some kind of depression. We also look at it from a biological perspective. There are variations. We do know this. There are variations in neurotransmitters that do affect brain levels. Okay. And I would say this is probably our best explanation for bipolar disorder. It is a brain activity that oftentimes occurs. And that has to do with their environment, right? And of course, the cognitive perspective just might be bad choices. Maybe they're not capable of making good judgment calls in their life, which leads to those periods of feeling good, and when they're crashing, feeling low, right? So there are many explanations to that. So, but again, I kind of put this up on the screen for you to kind of just view. Let me see if I can get it. So it's inflated self-esteem and grandiosity. That's usually in manic episode, decreased need for sleep, more talkative than usual. So somebody that is, normally they're just pretty reserved or normal talking, all of a sudden they just have these flight of ideas every couple of months. That might be expressed through talkativeness. Distractibility, right? ADHD, this comes to mind. In fact, we're considering looking at a connection between onset of bipolar disorder in children with ADHD. And I'm not saying that because they have ADHD means they're going to have bipolar later, but we are seeing some very similar traits like distractibility and flight of ideas, increase in goal-directed activity, right? So maybe they want to build a boat. They've never built a boat in their life, but gosh darn it, they're gonna put all their money into building a boat today. And then excessive activities that have high potential for painful consequences. Okay, maybe like promiscuity and sexual behavior or something. We might see that. All right. Any questions or comments on bipolar? Yeah, y'all still with me?
Yes.
Of course.
Okay. All right. So I'm going to skip eating disorders. I'm going to skip sexual dysfunction because I want to talk about personality disorders and then hopefully schizophrenia. Okay. So personality disorders. Briefly, personality disorders are very, very hard to diagnose and treat. And the reason being is we talked about personality, and personality are somewhat stable throughout our lives. They're ingrained in us. It's from the time of birth, we start developing our personality. So if we have a kind of a dependent personality or an avoidant personality, those carry with us for the most part through the rest of our lives, unless something significant changes that, either an event or a relationship or some kind of intervention of some sort, right? So they're persistent maladaptive behaviors that occur really over the life of a person. So they're lifelong, they're persistent, and oftentimes they're maladaptive. Okay. So this affects how they interact socially. Okay. And I'm going to break these down into 3 classes. So the first one we have are odd and eccentric personality disorders. And I'll go by each one of these here in a minute. The other one we have is dramatic and emotional, or erratic. Actually, I'll just put erratic and emotional. And then the third one is anxiety and fear. So these are the 3 classes of personality disorders that we usually see in the field. So odd and eccentric, it's just probably the most the most common type that you see is paranoia, right? People with paranoid personalities, they're always worried. They're always thinking that somebody's looking over their shoulder, right? They think that the government is listening through us through Alexa, for example. Having any kind of suspicions that either the government's watching them or a family member is perhaps unfaithful to them, that might be more along the paranoid side. We also have schizoid and schizotypal. Oops, schizoid. Now this is has little to do with schizophrenia, kind of, but when we look at schizotypal, what they're looking at is their ability to blend in with society. Okay, maybe they have some really eccentric ideas that they don't necessarily fit into society. I think probably the most most homeless populations fall under schizoid or schizotypal. And reason being is because they have ideas that they don't need money, right? They don't need to have worries that the government's going to take taxes from them. So they choose not to be part of society in most cases. Some people, not necessarily. They may just have had a bad run of luck and wound up on the streets. But for most people that don't want to get back into society, we usually see them in one of these three, in the odd eccentric class. Okay. Dramatic, emotional, and erratic. We see antisocial personality disorder. We see borderline, and histrionic, and the other big one I'm going to put on here is narcissistic, in the interest of saving time. Okay, so these are emotional. These are people that tend to have a guarded wall around them, okay, for whatever reason. It could be lack of self-esteem or self-efficacy, but where they lack in those areas, they kind of build up in other areas, okay? So for example, somebody that might feel naturally insecure depends on people. They put all their emotional worth in a relationship, which we call dependency. Okay. And they might do some very severe things to stay within that relationship. They might try and get pregnant just in order to keep somebody in that. You know, they do harm to themselves in order to stay in that relationship, which, you know, in turn, we many of you probably are aware or know of that people that engage in that kind of secure of relationships tend to wind up in abusive situations, right? Because they'll do anything, right? Narcissistic personality, you know, that doesn't need a whole lot of explanation. Is somebody that has delusions of grandeur. They think that they're better than something than what they are, right? And that could lead to a lot of problems. They could alienate caring relationships that are around them because they're so self-serving and self-absorbed in what they're doing that it's actually doing harm around them to their family members and friends. Okay. And they may be self-destructing in some way that they're not even aware of because, again, delusions of grandeur are telling them, hey, I'm good here. And of course, antisocial is marked, you know, we could probably spend an entire day talking about antisocial, but we see that on people that, again, are self-serving. They do things for themselves. They tend to lack remorse. They don't show remorse. They're very, they know how to be charismatic in order to gain things from people. They tend to be self-destructive and sensation-seeking, disregarding the safety of themselves and the people around them. Those would be examples of antisocial. And of course, our third category is anxiety or fear. And we talked a lot about that, like avoidant people that tend to avoid anything that's stressful, you know, tend to just be non-confrontational, right? And that could be a problem. And then OCD, obsessive compulsive personality type. I'm not going to say OCD. It's actually OCP. Okay. All right. So that's it. So, and again, personality disorders are probably by far the hardest to treat just because it's embedded. It's deeply embedded in that person. All right. Last but not least, let's talk about schizophrenia. Schizophrenia, we classify this as a mental health disorder. However, most publications really look at schizophrenia as being a neurological disorder. Why? Because all the other ones we can explain through some kind of cognitive approach or dealing with trauma or something adapting to our environment. Schizophrenia, on the other hand, is very much different in that it has features of it that aren't explained through learned behavior. For example, delusions of thoughts, right? Hallucinations, hearing voices and seeing things or smelling things or tasting things that aren't there. It's a disorder in the brain. It's not anything that's necessarily learned. It is treatable, and it takes a lot, usually medication to treat schizophrenia, but it is very, very treatable. But the person has to be able to accept that. We do see a lot of benefits, believe it or not, to schizophrenia. I'm not saying that these features are necessarily bad. In fact, they have some positive features. In fact, we break these down into positive symptoms and negative symptoms. Okay. And so some of those positive symptoms are delusions, right? They are devout in their belief in something, right? That's a positive symptoms. And the other one is hallucination. Now, you might think that these aren't great symptoms, but these are ones that are non-harmful. They're non-harmful to the person. They can be unshaken in their belief or their thought and still exist in society and not alienate people. Sometimes they do, but they're for the most part, it's not harmful. Hallucinations, not necessarily a bad thing. In fact, maybe kind of cool, right? You hear a voice or see something that's not there. That is not anything that's going to harm them necessarily. Now, if we start looking at negative symptoms, they could be absence of some of these positive symptoms. We could see poor attention. We could see flat affect. We could see inappropriate behaviors, like they go to a funeral and they start laughing. Those will alienate them and make their social situation a lot worse. We also see poor speech production, which we in the field know as a word salad. And that might just be a jumbled mess of word or tangential thinking. They just go off and spin off and say something nonsensical for 30 minutes, probably like I've been doing for the past half an hour. And I'm joking, but that would be an indication of poor speech production. Okay, and that happens within the brain. They might be thinking of something as they're talking about something else, and that word just comes out. So it's very, very neurological. We do know that there's a high rate of genetics within schizophrenia. For example, monozygotic twins. If they have two twins that are identical twins that are raised separately in different environments, we can show almost to 50% of those twins that if one has schizophrenia, the other one does, even though they are from different environments. So it is a very genetic. We are seeing a lot of high prevalence in hereditary and genetics with that. So even parents, if we have one or two parents that have that, the likelihood that the child has that, even separated from the home, might still show symptoms of that. Okay. And some of those symptoms here, once again, are having two or more of these for a period of time of 1 month. Now, it's important, very, very important. If any of you are working in the field and somebody comes through with any of these symptoms, to rule out any kind of medication. Okay. Or even substance. So for example, if they're smoking weed 7 times a week, that might explain some of the delusions and the hallucinations and disorganized speech and even attention, like some of the negative symptoms. Okay. If they are on a medication that might be causing that, and they're having a side effect reaction to that, that might be an explanation for some of these. So it's very, very important to rule out any kind of substance use that might be causing these. Okay. And of course, period of time for 1 month, and at least one of these points must be 1, 2, or 3. So they must have either delusions, hallucinations, and or disorganized speech, as well as another one of these. Okay. All right. I know that I raced through that at breakneck speed, but are there any questions? How did you all like that? Did it make sense?
A lot. Makes a lot of.
Okay. So I'm seeing a thumbs up from you, Nicole. All right. Good to see.